welcome to Breakfast at UMHealth webinar series. Assalamualaikum and very good morning to all of you. Today we are very fortunate to have Dr. Julian Wong, junior lecturer from Department of Psychological Medicine, Faculty of Medicine, University of Malaya, who will be talking about COMISA. Yeah, COMISA is actually a short form for comorbidity of insomnia and also obstructive sleep apnea, or OSA. Yeah. So today we'll be talking about topic that very interesting, new to the field of psychiatry, even though it's already been described many years ago by a sleep medicine specialist, Julian, from France or Paris, who are currently not currently, he's already passed away. Previously he was working in Stanford sleep medicine center. So today we will start with a talk from Dr. Julian Wong. Let me introduce him. He's actually a graduate from the Monash University, MBBS. And then after that, he pursued his study in University of Malaya, and just actually joined our department after he completed his Master of Psychological Medicine, University of Malaya, somewhere around, I think, last year, if I'm not mistaken. So just a little bit intro about this COMISA. I don't want to go in details, but just probably some brief on insomnia itself, which is a very common incidence, quite high prevalence, especially after MCO. We know that many people can't sleep. So insomnia is basically inability to sleep. When you put your head on the pillow, it takes more than 1 hour or increased latency. We say that people suffer from insomnia. Basically, is a diagnosis by exclusions. It can be acute or also chronic insomnia. I think I want this to further clarify by Dr. Julian Wong, who will also connect us with OSA and how these two conditions can interact each other and complicate the illness, and how do we address this problem in terms of management in our clinical practice. So without further ado, I would like to pass over to Dr. Julian, please.
Thank you, Prof. Rusdi, for the very kind introduction. Good morning, everyone. Before I start, allow me to just first share my screen. But we're very fortunate today to have Prof. Rusdi moderating us, as he is also the president of the Sleep Disorder Society of Malaysia. And so he's considered the foremost expert in this content here. So it's very good that hopefully we can have a very fruitful discussion at the end of this short presentation. So as he has mentioned, so today I'll be talking about comorbid insomnia and sleep apnea, otherwise known as COMISA. Unfortunately, it can be described as a double whammy in certain populations. And you'll be wondering why a psychiatrist would be talking about sleep disorders. Well, actually, sleep complaints form a major bulk of the complaints that our patients face, and they come and see us and are affected by it. So hopefully, by shedding some light into what we can do in terms of managing sleep disorders properly, we can improve their quality of life and also patient satisfaction. So without further ado, allow me to jump in today's discussion. It'll be a very brief introduction about insomnia, obstructive sleep apnea, and also COMISA, some prevalence data. We'll be talking a bit about what the literature has to say about this condition, and followed up by a case study, as well as discussing on diagnostic and also management issues arising from COMISA itself. So let me just jump in, and today's discussion is mostly based on salient points from this review published in 2019 by Dr. Alexander Sweetman and his colleagues from South Australia. And let me just introduce to you, insomnia and OSA are actually two most common sleep disorders affecting the general population. Both conditions share common similarities. In this case, they cause nocturnal sleep disturbances, impairments to daytime functioning and mood, as well as impairments to the quality of life, and results in high healthcare utilization as a result of the above disturbances. Now, comorbid insomnia and obstructive sleep apnea is highly prevalent, and unfortunately, it worsens the presentation of both insomnia and OSA individually, hence causing more difficulties in treatment because each individual condition is treated differently. So it causes a very complex diagnostic dilemma because of its very confusing presentation, and treatment decisions for clinicians is at a conundrum. However, despite it being so complicated and so confusing, there is very little research attention for almost the past 30 to 40 years. So it's time for us to take a closer look at what it is. So let's start with insomnia. It is defined by frequent and chronic self-reported difficulties. Rather, it is due to sleep initiation, sleep maintenance, and also early morning awakenings associated with impaired daytime functioning, mood, and quality of life, which is quite straightforward because as long as the patient experiences bad sleep, the rest of the day cannot go on as smoothly as it should be. Now, insomnia estimated to affect approximately 6 to 10% of the general population individually by itself. And one of the mainstays of treatment, or rather the gold standard of treatment for insomnia, is actually CBTI, cognitive behavior therapy for insomnia. But unfortunately, CBTI requires highly trained psychologists or therapists that are specializing in this field to administer. So many insomnia sufferers end up receiving just prescriptions for sedative hypnotic medications such as benzodiazepines or Z-class drugs as their initial and also ongoing treatment due to access issues. Now, what about OSA or obstructive sleep apnea? Well, it is characterized by repetitive brief closure or narrowing of the pharyngeal airway during sleep. So we can see that it is a combination of anatomical and also non-anatomical factors at play here. So the prevalence of OSA is estimated to affect about another 10% of the general population. And in this case, because of the anatomical implications, the most effective treatment for moderate to severe OSA is actually continuous positive airway pressure therapy, in which we maintain the patency of the airway. So as you can see, it's not via pharmacological or psychological interventions. However, the drawbacks of CPAP therapy requires the patients to wear a pressurized nasal. So this can be very discomforting and also very distressing to the patient as it tends to suffocate them. So this is limited by very poor patient acceptance and unfortunately very disappointing long-term adherence. So the patient is already experiencing difficulties with sleeping. Added on the suffocation, it's going to worsen their quality of life. Now, what about comorbid insomnia as well as obstructive sleep apnea, in which the cases of both symptoms, both constellation of diseases are coexisting in the same patient? Well, collectively, the research suggests that it's about 30 to 50% comorbid prevalence rate. There are recent studies indicating that the comorbid insomnia symptoms in COMISA can be treated with CBT for insomnia, CBTI, to increase the patient's acceptance for the CPAP therapy. Hence, going on together, improves better adherence and improving patient outcome. However, what's confusing here is that because the treatment of COMISA requires a sharp diagnostic consideration because we need to be able to pick up whether the patient is having individually insomnia or individually OSA, or at the same time, they're having both components together. So it tends to present different diagnostic and management challenges to both physicians as well as the psychologists. So what does the literature say about COMISA in general? Let's dive into the data. So as mentioned by Prof. Rusdi earlier, Gilmore and his colleagues back in 1973 itself has actually been talking about this comorbid insomnia and obstructive sleep apnea. And back in 1973, they estimated that among, they look at the data of 56 patients, but they extrapolate that among people with chronic insomnia, approximately 10% of them do have OSA symptoms as well. So it's not just the perceived nocturnal sleeping difficulties, but there are also anatomical connotations affecting their sleep quality. Now, this raises the highlight of concerns of benzodiazepine use among COMISA patients, because as we know that the benzodiazepine usage is a treatment for insomnia, but when used in patients with OSA symptoms, it might actually worsen the airway obstruction, thus debilitating the patient instead of elevating their sleep complaints. So these findings, this 10% of patients, they highlighted the importance of assessing insomnia patients for OSA symptoms, because the gold standard treatment at that time is just not adequate to address this population of patients. Now, looking at separate studies back in the 1990s, early 2000s, up to 2010, they found out that among insomnia patients, a significant portion of them have what we call an apnea hypopnea index of at least 5 and above, demonstrating that these patients do have not just insomnia, but also OSA problems, as much as up to 58 to 60% of this population. And also another study, they look at veterans, means they are retired military personnel. They look at 600 veterans with OSA, and they, at the same time, they flip the study, and they look into people with OSA having insomnia symptoms, and they find that around 30% of OSA patients do have insomnia problems. Now, how they do this? They use the ISI, what we call Insomnia Severity Index, which is just a simple seven self-report items that allows them to objectively scale the severity of insomnia. So which include 3 nocturnal items, such as difficulties in falling asleep, staying asleep, and waking up too early, and 4 daytime symptoms, which includes satisfaction with sleep, daytime functioning interference, quality of life impairment, and worries of distress. So looking at total of 28 scores, 28 points. So the higher the scores indicate the more severe the insomnia, and more than 15 indicates clinically significant insomnia symptoms. So among these veterans with OSA, about 44% reports a score of more than 15%. So that is a significant burden of insomnia in these patients. So what happens when insomnia and obstructive sleep apnea exist together? So COMISA patients experience greater impairments to their daytime functioning and their quality of life as compared to those with only individual diagnoses. And they also express greater emotional and cognitive impairments, including mood irritability, reduced focus and concentration, onset of depressive symptoms, as well as onset of anxiety symptoms. So increasing the psychiatric burden among these patients as well. So what are the diagnostic challenges that face clinicians when a patient comes to us with sleep disturbances? Well, because they share overlapping symptoms, oftentimes we tend to overlook the other in making a single diagnosis. So patients tend to be diagnosed either with just insomnia alone or OSA alone without looking into the overlapping of COMISA's possibility. So the diagnosis and measurement of each disorder in the presence of the other tends to be very confusing to researchers and even clinicians. Now, that insomnia, on the other hand, is clinically diagnosed according to frequency, severity, and chronicity of their nocturnal sleep complaints and reflected daytime impairments. With the same symptoms tend to exist in OSA patients, hence confusing the whole clinical picture. Now, what can we do to improve on more effective diagnosis of COMISA? Well, we can use tools such as the AHI and ISI to help us objectively rank the severity of the patient's symptoms and then determine the correct treatment modality. Because if we don't clarify we don't draw the line between the diagnosis, COMISA patients that are just treated with CPAP therapy alone may actually report an improvement in daytime impairments, but they might have worsening insomnia severity because we're not addressing their insomnia needs, as opposed to COMISA patients that are started on maybe CBTI. They do not report improvement in their OSA symptoms because the anatomical obstruction is still present. So we need to avoid overlooking the patient's complaints on both spectrums. So as I mentioned earlier, using our rating scales to assist with ranking the severity of the individual components helps in clarifying the diagnosis. As I mentioned earlier, the AHI for OSA and ISI for insomnia. And how about managing COMISA? So of course, in this age and time, we look into evidence-based practice. Now, we know that CPAP therapy is the most effective treatment for moderate and severe OSA. And however, because of the presence of insomnia, they tend to reduce the patient's CPAP acceptance and use. Now, this is because patients spend more periods of time being awake at night, wearing the pressurized CPAP mask because they are discomfort and perceived suffocation. And they're also more likely to remove the CPAP equipment during the night because of that suffocation, or reject the therapy entirely, thus not addressing any of the cause of the complaints. So COMISA patients actually should be referred for insomnia treatment before commencing CPAP therapy to improve adherence, because CBTI not just look into patients' insomnia deficiencies, it also can form a sort of psychoeducation to get them used to the idea of wearing a CPAP, thus reducing their reluctance and also improving their compliance. In fact, recent data from 145 patients with comorbid insomnia and sleep apnea, they are ranking with moderate to severe OSA, finding that prescribing CBTI first leads to greater improvement in their ISI scores, even their daily sleep measured, diary sleep measured parameters, as well as their dysfunctional beliefs that by post-treatment, their symptoms are actually worsening instead of improving, compared to a no treatment control group. So CBTI is an option to introduce the concept of CPAP to patients with COMISA. Now, hence, clinicians should administer sleep diaries or the insomnia severity index, which can be scored by the patients themselves to screen for symptoms of insomnia in cases of suspected OSA. And these patients should be treated with both CBTI and CPAP therapy to improve both insomnia and OSA symptoms at the same time. However, this will involve a multidisciplinary effort because the CBTI should be delivered by trained psychologists, and the CPAP can be administered by the clinicians themselves. So let me just share with you a clinical scenario just to demonstrate how confusing the diagnosis of COMISA can be on the get-go. We're using an example of a middle-aged tour agent who actually visited Prof. Rusdi's UMSC clinic. So this is a 60-year-old gentleman visiting Prof. Rusdi's clinic with a complaint of sleep difficulties for the past 6 months. And he has difficulties falling asleep associated with intermittent awakening and sometimes an inability to continue sleeping for no absolute reason. So clinically sounds like a picture of insomnia. He reports no anxiety, depressive, or psychotic symptoms. Thereupon, there's no psychiatric comorbidities at this point in time. With regards to his substance history, he has never smoked, nor has he used any illicit substances, and he only drinks alcohol or consumes coffee on social occasions. So not a very high risk factor there. And he has no significant past psychiatric history, and there's no family history of mental illness. Sounds on paper like a very straightforward insomnia case. Medical-wise, he is diagnosed with hypertension, and he was prescribed on amlodipine 10 milligrams, and there was no issues with tolerability of the medication, nor were there any symptoms of failure, which might present with shortness of breath and difficulty with sleeping. So all in all, a very clear-cut insomnia picture. And to address his sleeping difficulties, he's actually been seeing a general practitioner before coming to see us in UMSC. And he was prescribed on hypnotic tablets, a Z-class drug called zolpidem, and was using up to 20 milligrams daily. And we can see that this trend of usage has been increasing over the last 3 months, signifying that the patient has somewhat developed dependence and also tolerance to the medication. Now, mental state and physical examination were unremarkable for this patient. So he was not overtly depressed, nor was he psychotic, nor was he suicidal. And there was no significant physical examination findings. His vital signs were within normal parameters. And he has a BMI of about 20 meters per kilogram squared. So not entirely an obese individual. Hence, the consideration of OSA was not in the picture at that point in time. ECG showed sinus rhythm, and blood investigations were all within normal parameters, and his thyroid function test was normal. So he was diagnosed with chronic insomnia based on the chronicity of his complaints of more than 6 months. And he was commenced on tablet lorazepam, 1 milligrams daily, and also PRM basis, so which is a benzodiazepine class. And he was also given sleep hygiene education as part of his initial treatment. And he was scheduled on follow-up for 2 weeks. However, 2 weeks later, he reported instead of elevation, but worsening of his sleep problems with daytime sleepiness, extreme lethargy, as well as cognitive deficiencies, such as poor focus in his job. Bear in mind, he's a tour agent, so he needs to be alert during the daytime. And his wife also reports that the patient has started snoring, and there were pauses in breathing during his sleep. So there were apneic episodes there. So his clinical impression now has somewhat evolved or somewhat been uncovered that there's an element of OSA co-occurring with his insomnia. So his lorazepam was actually discontinued because, as we know earlier, the presence of a benzodiazepine might actually worsen the OSA symptoms. And a polysomnography was ordered. So a sleep study was ordered. And the report came back later as severe obstructive sleep apnea. Well, bear in mind, despite normal BMI, anatomical differences can occur in patients with normal BMI as well. So because of that, he was started on CPAP treatment, but there was poor response due to poor compliance. He felt suffocated by it. He felt that he cannot comfortably utilize the CPAP effectively, hence he takes it off and he just doesn't use it anymore. So this presents as a continuous vicious cycle, and the patient is not getting better. And he, on return to follow up, he was subsequently referred for CBTI instead with a psychologist to address his insomnia issues, as well as his reluctance to use the CPAP therapy. Now, a month later, after commencing on CBTI, the patient reported that his sleep has actually improved. And his wife informed that he has no more snoring at night, and he is more compliant to his CPAP therapy. So with that, he's able to self-reduce and eventually stop the use of his zolpidem and lorazepam entirely. And right now, he only requires what we call tablet lamborexine, which is a new orexin antagonist agent that we can use as an alternative for sleep disturbances instead of the traditional benzodiazepines or the drug class. And he uses this tablet on PRM basis to maintain his sleep. And he has reportedly returned to full functioning, and quality of life has significantly improved for this tour agent. But what he can demonstrate here was that how difficult it is to pick up elements of insomnia and obstructive sleep apnea individually from the get-go on first presentation. And patients will have long periods of frustration as they will try on one modality of treatment and facing resistance because of the main complaints leading to the initial presentation were not addressed effectively from the get-go. So wrapping up, clinicians are recommended to utilize very simple instruments to help detect insomnia symptoms in OSA patients. So we have tools such as the Apnea Hypopnea Index, which helps rate the severity of OSA, which can be found online and can be administered on the clinic table site very effectively. We also have the Insomnia Severity Index, which helps us rate the severity of insomnia, which also can be administered from the bedside or the clinic table site very effectively. Both gives us an objective ranking of the patient's symptoms. And if the patients rank high on both, we can say that this patient fulfills the criteria of COMISA. And once they are identified to have COMISA, we should refer them for combined CBTI and CPAP therapy and not individually by itself. Of course, further research should be done to examine the bidirectional relationships between COMISA and also to continue refine and tailor different treatment combinations and sequences rather than what we have right now, which is a lot of trial and error and a lot of wasted patients' time and also reflected in very poor quality of life. Of course, having said that, as clinicians, when we see patients coming to us with sleep difficulties, we should also support and discuss with them the unmet needs of suffering from sleep disturbances like the loss of productivity, any potential comorbidities that might complicate their treatment and response? Is it because of side effects of medications, or their premorbid physical inability to adhere to treatment? Or are there any associated psychological issues arising from these sleep problems, such as depression, anxiety, or bipolar disorders that we need to address? So, effectively managing a patient with sleep disturbances such as COMISA requires collaboration and multidisciplinary approach towards addressing sleep difficulties. This is not just in the domain of the sleep disorder experts. There are also psychological and psychosocial interventions involving the outpatient services at the Department of Psychological Medicine in PPUPN, for example. With that, these are my references, and I thank you for your time. Back to Prof. Rusdi.
Many thanks, Dr. Julian Wong, for very impressive coverage of COMISA in our live webinar today. So maybe I just wanted to highlight here. There is one question from the audience. Mr. Tami, he asked, how many percentage of COMISA patients get well with the CBTI treatment that been given in UMMC? Let's see whether you can answer that.
That's a very good question.
Yeah.
That's a very good question, Prof, actually. But unfortunately, if we're asking in the setting of UMMC alone, unfortunately, we currently have a logistic and I would say human personnel deficiency. We don't have a dedicated psychologist right now because our psychologist is currently on study leave. He'll be back sometime next year. So unfortunately, we are unable to administer CBTI for our patients in UMMC right now. So I am unsure if there's any has been done before his departure. But as far as I'm aware, because he's been away for the past 1 year or so, there's no definitive data on it. But in private setting, I think the successful rate is quite promising. I'll need to defer to you, Prof. Rusdi, for this one.
Okay, thank you. It is right as what been mentioned by Dr. Julian Wong. We don't have enough psychologists at this moment in UMMC, but of course we are not really let the patient like that. We still give services. Even we ourselves as psychiatrists, we do CBTI on our own, but our time is very limited. Maybe not as what we mentioned in the literature, where you need to give at least few sessions. Maybe 1 or 2 sessions is enough given by us. And of course, I think as a psychiatrist here, we need to routinely screen for any patient who came to see us with regard to problem with insomnia, with the incidence of comorbidity with OSA. If we see that they are not improved with our routine treatment, antidepressants, sorry, not antidepressants, I mean hypnotic drug like benzodiazepine, as mentioned, lorazepam or clonazepam or whatever, we should actually screen them for OSA as well. If you're not really know how to screen for OSA, you can also refer to our sleep medicine specialist, either respiratory medicine specialist or even ENT specialist to tackle that part. And of course, we need this multidisciplinary approach in order to manage patients with COMISA well. I think not only insomnia that we need to looking after with regard to comorbidity with OSA, even our primary psychiatric problem like schizophrenia, even major depressive disorder and anxiety disorder is also frequently comorbid with OSA as well. So if you see any of our patients who have a similar problem with benzodiazepine treatment, so we may also screen them for OSA and do a referral to sleep medicine specialist if necessary. So I take opportunity here to also announce that as a member of the Sleep Disorder Society Malaysia, we will have a sleep regional conference, Sleep 2024, in UiTM Shah Alam Hospital Sultan Rublah, this coming 23rd to 26th of September this year. So I hope those persons who are interested, including the public, they can also attend this sleep conference 2024, which is a regional one. We will be attended by many sleep medicine specialists from this region, including Thailand, Indonesia, Philippines, and also China as well. So with that, I would like to thank you for all the audience. Give back to the secretariat. Thank you very much.